Well, welcome to this video series. It's actually 5 videos that I've put together into one here. Now, the first one is on the anatomy and physiology of the circulatory system. So if you're not quite sure about the way the heart and the lungs all fit together with the systemic circulation and the pulmonary circulation, then do watch the first part of the video. If you're already familiar with that, you want to perhaps go on for the first 10 minutes of the video and then look at the latter part of the first section where we think about lung disease causing heart disease via the mechanism of pulmonary arterial hypertension. And then the second clip, we look at systemic arteries. So the first one's looking at pulmonary arteries, the next one is systemic arteries. And here we're thinking about systemic arteries and hypertension, high blood pressure, which is such a common global problem. The third part, still looking at systemic arteries, considers the problem where atheroma is laid down inside the arteries in the disease process of atherosclerosis. The fourth clip looks at systemic veins. Because the systemic veins drain into the right side of the heart, therefore if there's a right ventricular failure, the blood will dam back into the systemic veins. And we'll see the complications of that. And then the fifth one is relating to the pulmonary veins. Now, because the pulmonary veins drain into the left side of the heart, left ventricular failure can affect the pulmonary veins. And we'll see that that leads to pulmonary edema, amongst other complications. Now, there are a separate series of videos on the Campbell teaching channel where we look at heart disease in more detail. There's another series where we look at the cardiovascular system in more detail, so do check those out. But if you want an overview of diseases of the cardiovascular system, through the lens of looking at these different arteries, looking at the pulmonary arteries, the systemic veins and the pulmonary veins, then this would be a good place to start. It takes a while, but if you persevere, I think it'll give you a good handle on the topic. Well, in these videos, we want to think about the disorders of the circulatory system. So what we always like to do on these videos is start with some anatomy and physiology. So we'll start with the heart. So the heart's got valves pointing up the way just here. And this wall becomes thinner about here. Now these valves pointing up the way, these give rise to the large arterial vessels. This one is the aorta, the large vessel leaving the left ventricle. And there's a valve just here pointing down the way. And blood vessels actually enter this top chamber, the atria. So this is the left atrium here. There's actually 4 of these vessels, but we're just drawing a simplified diagram. Valve pointing up the way on the right side of the heart, again leading to a large vessel. This one's the pulmonary artery. Valve pointing down the way. And again the atrium at the top with blood vessels going into this. So we have the left atrium and the right atrium, the left ventricle and the right ventricle, the aorta and the pulmonary artery. This vessel here is going to be representing the pulmonary veins. This vessel here is representing the inferior and superior vena cava. This is the mitral valve, this is the aortic valve, this is the pulmonary valve, and that's the tricuspid valve. So that's the basic heart. Now the aorta is taking blood into the systems of the body. So here we have the systems of the body, represented by this mass of tissue. Now the systems of the body are going to include the digestive system, the renal system, the gastrointestinal system, the liver. It also includes your legs and your arms and your brain. It's all the systems of the body here. So for this reason, we call these the systemic arteries. So these are the systemic arteries. The aorta is the first of the systemic arteries. Whereas this artery is going to the lungs, so this is the pulmonary arteries. So we've got the systemic arteries here, the pulmonary arteries on this side. And as we've said, these are taking blood to the body. When the blood's been round about the body, it will go back in the venous return to the right atrium, ultimately via the inferior and superior vena cava. The pulmonary circulation, of course, is going to the lungs, so this mass here represents the lungs. And we have the lungs. Then the vein draining, there's going to be a vein draining the lungs. Two main veins from each lung actually drain back into the left atrium. And there we have the outline of the circulation. Now, it's worth just colouring this in a bit. Blood's going to go from the left atrium through to the left ventricle, and we draw this blood in red because it's fully oxygenated out through the aortic valve and into the body. As the blood goes through the body, it gives up some of its oxygen. So to represent the darker red deoxygenated blood, we have the blue, taking blood back to the right atrium, right ventricle, into the pulmonary artery, or the pulmonary arterial system, to go to the lungs. As it goes through the lungs, it's going to be oxygenated, so it's going to leave in fully oxygenated form, going back to the left atrium. Now, a lot of the diseases of the circulatory system can be explained in terms of pressure changes in these vascular systems. So we've got the systemic arteries going to the systems of the body. So these veins here draining the body are the systemic veins. That's the systemic venous system. This system here, draining the lungs, this one, are the pulmonary veins. The pulmonary veins. Now, actually, of course, this is simplified. We could go on teaching this basic physiology forever, but basically, as you probably know, the arteries here are going to subdivide into lots of smaller branches, taking blood to all of the body, eventually becoming arterioles going into networks of capillaries. Then the capillaries are going to drain into venules, draining into larger veins, and eventually becoming the inferior and superior vena cava. And it would be a similar situation in the lungs. The pulmonary artery is going to break down into smaller branches, going into pulmonary capillaries, which are in very close proximity with the alveoli when oxygenated. And they're going to join up with other ones and eventually become the 4 pulmonary veins. So what we need to think about is the pressures now in these vessels. Now, the pressure in the systemic arteries is maybe 120/80. But of course, this is above atmospheric pressure. So we always have to 760 millimeters of mercury is the atmospheric pressure. So that's above atmospheric pressure. And we notice there's two pressures, 120/80. And that's because there's systole and disystole. Now, systole is when the ventricle is contracting, or ventricular systole is when the ventricles are contracting. So as this ventricle contracts, going to increase the pressure of the blood in the ventricle, ejecting the blood into the systemic arteries. And that's going to generate a pressure of about 120 millimeters of mercury. Then when the left ventricle finishes contracting, the time when the ventricle is not contracting is ventricular disystole, and the pressure is going to drop. But the pressure is maintained by the elastic recoil of the arteries. So the blood is going to be pushed into the arteries, but then because they're elastic, they're going to kind of spring back, maintaining the diastolic pressure. So 120 systolic, 180 diastolic. And of course, this blood has to go all around the body. It has to go to your, to your head, to your toes, everywhere. So we need a fairly high pressure. That's why the left ventricular myocardium, as we see here, is quite a thick muscle. As indeed is the muscle in the interventricular septum. Whereas the muscle on the right side of the heart is thinner simply because it doesn't have as far to pump the blood. It's much further to your toes and your head than it is just to go to your lungs, which are also in the thoracic cavity, of course. So the pressure in the pulmonary arteries might be 20/12. I mean, they're going to vary a bit, but there's that kind of pressure. So 20 millimeters of mercury when the right ventricle is in systole, when the right ventricle is contracting. 12 millimeters of mercury when the right ventricle is not contracting, during disystole. And we can also put pressure on the pressure figures on the veins. So, for example, in the pulmonary veins, the pressure here might be 12 to 14 millimeters of mercury. All these pressures are millimeters of mercury. And there's another pressure called the central venous pressure. CVP in the large veins here, and that might be 3 to 8 millimeters of mercury, 3, 4, 5, 6, 7, 8 millimeters of mercury, that kind of range. Now, the reason that the ventricles are contracting are to maintain blood pressure. So we need blood pressure. And blood pressure equals cardiac output times systemic vascular resistance. So the blood pressure is determined by the volume of blood pumped out and the resistance to that blood in the arterial system. Most of the resistance actually comes from the arterioles, the small blood vessels. And the cardiac output is equal to the heart rate times the stroke volume. So the heart rate is the number of times the heart is contracting per minute, and the stroke volume is the volume of blood pumped out by the left ventricle per contraction. And that works out at about 70 beats per minute times 70 mils, which is what the stroke volume is. So that gives us about 4,900 mils of blood pumped out per minute. And that actually is about the, give or take, it's 5 litres. Blood pumped into the systemic circulation. And that's pretty well the whole volume of blood being pumped into the... So all of this here represents the systemic circulation. And in the same way, this here represents the whole pulmonary circulation. So there we have the normal circulatory system. Now what I want to do now is look at some abnormalities of this system. And I think we'll start with the pulmonary arteries and work round. So, for example, there's a condition called pulmonary heart disease. In the old days, this used to be called cor pulmonale. And there's two forms of pulmonary heart disease. But in both of them, the pressure in the pulmonary arteries is going to increase. So in pulmonary heart disease, there's going to be pulmonary hypertension. There's going to be increase in the pressure in the pulmonary arteries. And what pulmonary heart disease is, it's actually heart disease caused by a problem in the lungs. And there's two forms. It can be acute or it can be chronic. So there can be an acute pulmonary heart disease caused by an acute pulmonary hypertension, or there can be chronic pulmonary heart disease caused by a chronic pulmonary hypertension. Now, the acute form, for example, can be caused by venothromboembolism. So if we look at the word, veno to do with the veins, thrombo, a thrombus is a blood clot where there should not be one, and an embolism is when that blood clot moves in the venous system. So very often venothromboembolism can be caused by a deep venous thrombosis. A deep venous thrombosis. And we can actually plot what happens here. Because in a deep venous thrombosis, the problem is going to start in the systemic veins. So there could be a blood clot in a vein here in the leg. And as an embolus breaks off that, it's going to go through the right side of the heart, through there. Now, if there's an embolus breaks off here, as it goes through these vessels, these are getting larger all the time. And the chambers of the heart are fairly large, so it can fit through there. But then when it comes to an artery that it can no longer fit through, it's going to get blocked off. It's going to block off a segment of the pulmonary circulation. So it's a thrombus there where it formed, then it embolizes, and it's the emboli that goes through the circulation. So let's just follow that again. From a systemic vein, draining through the systemic veins, right atrium, right ventricle, pulmonary artery, lodging in the pulmonary arterial system of the lungs. And then we would call it a pulmonary embolism. A pulmonary embolism. Now, how severe this condition is depends largely on how big it is. A huge one could block here. But I think you can see if it's blocking off the pulmonary circulation, that means the blood's going to be forced around other parts of the pulmonary circulation. So that means there's going to be back pressure, and it's going to increase the pulmonary arterial pressure if it's a large embolism. So that will be venothromboembolism presenting as deep venous thrombosis and pulmonary embolism. And of course, we normally say DVT can go to PE. Deep venous thrombosis can go to pulmonary embolism. Now, the chronic form, for example, can occur in chronic obstructive pulmonary disease. COPD. Now, what happens here is in chronic bronchitis, there's not enough air getting into the lungs. So areas of the alveoli are going to be low in oxygen. And when that happens in the pulmonary vessels, the low levels of oxygen cause a reflex pulmonary arterial vasoconstriction. So this is going to cause pulmonary arterial vasoconstriction. In the pulmonary vessels. It's going to be in the pulmonary vessels. Now, physiologically, that's good because it means that a lot of blood normally does not go to areas of the lung that don't have oxygen to pick up. So that's good. But in this situation, in COPD, all of the lungs are going to be involved. So there's a deficiency of oxygen in the alveoli all over the lungs. So that means all of the pulmonary vessels are going to close down. There's going to be a global pulmonary arterial reflex vasoconstriction in response to the reduced levels of oxygen in the alveoli. And if we constrict the vessels, that's going to increase the resistance, and that's going to increase the pressure in the pulmonary artery. So again, the COPD causing the vasoconstriction of the pulmonary vessels is going to lead to the pulmonary hypertension. And that's bad because over time, because the pressure here is high, the pressure in the pulmonary artery is high, is that going to mean the right ventricle has to work harder or less hard to pump the blood out? Well, if the pressure in here is high because of the vasoconstriction in the pulmonary arterial system, I think you can probably see that's going to increase the right ventricular workload. It's going to have to work harder. And if the right ventricle has to work harder, over time that's going to cause ventricular hypertrophy. And over time, that's going to lead to left ventricular failure. Sorry, right ventricular failure. Let's just clarify that. The right ventricle has to work harder. That's going to cause right ventricular hypertrophy. There's going to be an overgrowth of the right ventricle. But over time, it's going to decompensate, and that's going to lead to right ventricular failure. Now, if we have right ventricular failure, the right ventricle is not pumping blood out properly anymore, then every time the right ventricle contracts, it's not going to be pumping out enough blood. So you're going to get blood left over in the right ventricle at the end of systole. Is that going to make it easier or harder for the blood to leave the right atrium? Well, if that's half full, it's going to be harder. So it's going to increase the pressure here. That's going to make it harder for the blood to drain out of the systemic veins. So we're going to get a back pressure here into the systemic veins. And we'll see that that will lead to systemic edema, but we'll do that when we look at systemic veins. So there we have the pulmonary heart disease, the acute and the chronic form. But in both of them, there's going to be pulmonary arterial hypertension. Acutely because of the presence of the emboli, or chronically because of the vasoconstriction in the pulmonary arterial vessels induced by the low levels of oxygen in the alveoli, giving rise to chronic vasoconstriction, chronic increased pulmonary arterial pressure, ongoing chronic increased workload of the right ventricle, leading to right ventricular hypertrophy and then right ventricular failure. So in the next video clip, I think we'll go on and look at the systemic arteries. Welcome to the second video in this series on disorders of the cardiovascular system. where we're looking at it from the perspective of the various blood vessels, or the various aspects of the circulation. So we've looked at the pulmonary arteries here, taking blood from the right ventricle through to the lung, or to the lungs, and we've noticed when you might get raised pulmonary arterial pressure. In this clip, we want to consider the systemic arteries. So what diseases affect systemic arteries? Well, we notice the normal blood pressure in the systemic arterial system is 120 over 80 millimeters of mercury, 120 systolic, 80 diastolic. Or that might be a blood pressure that you typically find. If you're young and fit, your blood pressure may be quite a bit lower than that. That's acceptable. In fact, it's good. So we're thinking about systemic arteries. These are the arteries that break down and take blood to all of the body, apart from the lungs. All the systems of the body receive their blood supply via the aorta. The first two vessels right down here that actually leave the aorta are the coronary arteries, the right and left coronary artery taking blood to the myocardium itself. So we notice the normal blood pressure there, and there's a common condition called hypertension. Hyper, of course, is high. Tension means pressure. So blood pressure can be too high. Now this can be primary, also called essential. Hypertension, or it can be secondary. Now this is the same with quite a few diseases. A secondary condition is one which is caused by something else, whereas a primary condition is one which just arises without apparent cause. So, for example, secondary hypertension is often caused by renal problems. The kidney is very closely involved in control of blood pressure. Problems in the kidney can give rise to hypertension. But other times you get your blood pressure checked and it's a bit high, and that can maintain forever if you develop it. Primary hypertension doesn't seem to be caused by any underlying pathology. It seems to start with the blood pressure itself. So it's also called essential hypertension. Both of these can be dangerous because high blood pressure is not a good thing to have. This one's probably, most cases, are probably because the kidney produces too much renin. And as you might know from other learning, that affects the renin-angiotensin system, which we do deal with in other videos. So it's very important for you to detect hypertension by checking the blood pressure. It's important to remember that the main clinical feature of hypertension is that there are no clinical features of hypertension. The most important clinical feature of hypertension is that there isn't any. We detect it by taking the blood pressure. And that's because blood pressure is auto-regulated throughout a wide variety of pressures. So with a blood pressure of 90 or a blood pressure of 160, the amount of blood going to your brain, for example, should be auto-regulated. So very often people are hypertensive but don't feel any adverse effects from that. We have to check it. So taking blood pressure is an essential part of every physical assessment. It has to be. Now, if the blood pressure is raised, we've got effective medications that can treat it. We've got a range of medications that can treat it. Angiotensin converting enzyme inhibitors, calcium channel blockers, even beta blockers, even diuretics. We've got a wide range of medication, and we've got well-established protocols for treating hypertension, and we can usually manage to bring the blood pressure down to highly acceptable levels. But if we don't, The problem is the hypertension causes complications. There are complications associated with hypertension. And these can develop silently because the patient may not be aware there's anything wrong with them. Now, the hypertension can occur on its own, or it can occur with obesity, or it can occur with the metabolic syndrome, where it can be associated with dyslipidemia, hyperglycemia, particularly in patients with abdominal obesity. But it can just present on its own. There's a genetic component sometimes, but again, not necessarily. And there are complications. One of the complications is atheroma. Develops in the blood vessels, the disease process of atherosclerosis. There can be atherosclerosis. Now, if the blood pressure here is high, what's that going to do to the left ventricular workload? If the pressure in the systemic arteries is high, can you see that means it's going to be harder for the left ventricle to contract, to pump the blood out against the increased outflow resistance. There will be an increased afterload. It was the same with the pulmonary arteries. When there was pulmonary arterial hypertension, that increased right ventricular workload. When there's systemic arterial hypertension, the left ventricle has to pump harder to pump the blood into the systemic arteries. Now, for a while it can do that. There can be enlargement of the left ventricular myocardium, left ventricular hypertrophy. Now, this condition is a hypertrophy because when you exercise a muscle, the muscle will get bigger. Like if you go to the gym and start working out, your muscles will get bigger. But that's because the individual cells get larger. It's a hypertrophy. There's not an increase in the number of cells. And over time, well, to begin with, the left ventricular hypertrophy will compensate, but then over time, the left ventricular hypertrophy will lead to left ventricular failure. So we'll get heart failure, start as left ventricular failure. So that will lead to heart failure. And if the left ventricle fails, if the left ventricle is not pumping the blood out properly, then that will mean that there's some blood left in the left ventricle at the end of systole. That's going to make it harder for the blood to get from the left atrium into the left ventricle. That means the blood is going to find it harder to get from the pulmonary veins into the left atrium. There's going to be a damming back. So because the blood's not effectively pumped out of here, because the left ventricle is failing, the blood will dam back to here, will dam back to here. So you're going to get a pulmonary venous hypertension, and that can result in pulmonary edema. So the left ventricular failure can result in pulmonary edema. Just the same way as the right ventricular failure means the blood is going to dam back, and that can cause pulmonary edema. If you follow the circulation back this time, you follow the path of the congestion. And left ventricular failure does not have a good prognosis. It's a very serious condition. The kidney is like a constant blood pressure, so there can be renal complications as a result of hypertension. And another big risk is stroke, cerebrovascular. Cerebrovascular accident, one of the primary causes of that is hypertension. So very important that the pressure in the systemic arteries does not become too high, so the person does not become hypertensive and therefore will not suffer the complications, of which we've just sketched out a few here. Now, if you recognise the hypertension and treat it, you can prevent these complications. and other complications. There's many more complications. Dementia, for example, is more common. So you can prevent this as long as you detect it. So that is one condition affecting the systemic arteries. The next condition on the next video clip we want to look at, also affecting the systemic arteries, is this disease process of atherosclerosis, which is still one of the major causes of premature death and suffering in the Western world, and unfortunately is becoming more and more common in developed countries as well. So we want to carry on our review of cardiovascular diseases now by considering another problem of the systemic arteries. So we've considered hypertension as a condition affecting the systemic arteries. Another common condition affecting the systemic arteries is atherosclerosis. Atherosclerosis. Now in atherosclerosis there's the accumulation of atheroma inside blood vessels. Now we're considering the systemic arteries here. So these are the arteries going from the left ventricle to all tissues of the body. And atherosclerosis can affect a wide variety of these vessels. For example, it can affect the coronary vessels, the coronary arteries taking blood to the myocardium. It can affect the cerebral vessels taking blood to the brain, because all tissues need a viable supply of blood. So any tissue we have, there's going to be an arterial supply. That's going to break down into smaller branches, and they're going to supply areas of tissue with blood. Of course, these are going to break down into numerous arterioles and smaller branches. But the tissue that this arterial branch is supplying blood to will supply blood to the capillary beds. This tissue, it's absolutely essential this tissue has an ongoing blood supply. This tissue cannot survive without its blood supply. It needs an adequate blood supply because it needs oxygen in the blood. It needs nutrients from the blood. And it needs a flow through of blood to remove material such as the waste products of metabolism, such as carbon dioxide. So that needs to be going on all the time. Now what happens in atheroma is, if we look at a cross-section of this artery here, and remember we're looking at a systemic artery, so if we relate this to our original diagram, we could be looking at an artery here, for example, supplying blood into the systemic circulation. And basically that's got 3 layers to the arterial wall. There's an outer layer, the tunica adventitia, or the tunica externa. And again, this is dealt with in more detail in other videos in this series, on the cardiovascular physiology, the A&P. And there's a thicker middle layer, the tunica media, and there's a thinner internal layer, the tunica intima. Now what happens in this disease process of atherosclerosis is that fatty material such as cholesterol gets through the tunica intima and starts accumulating just underneath the tunica intima. And again, we deal with this in more detail in other videos, but that's what happens. Then over time, what happens is you have the artery, the adventitia as normal, but underneath the tunica intima we develop an area of atheroma. like this, underneath the tunica intima. So that's the tunica intima there. And this will get bigger with time. And the bigger it gets, the more it's going to impose into the arterial lumen. Often occurs at the bifurcation, so it might start just a little bit where arteries bifurcate, but then it can get more extensive. And as it gets more extensive, I think you can see now there's less space here for the blood to get through. And the thing about this process, this atheroma, is it's associated with few complications, so let's look at those. So one is ischemia. Now ischemia is a reduced blood supply to the tissue. Another is thrombosis. That is a blood clot where there's not supposed to be one. And another is aneurysm, which is a weakness in the wall of the blood vessel. Because as the atheromatous plaque develops, you see that's all atheromatous plaque there now. That means that there used to be this distance here of viable arterial wall. Now there's less distance of viable arterial wall, so that's going to be weaker. And the lumen is going to be smaller because it's pressing in. So we get a weakened wall with less supply of oxygenated blood getting through. Now, the ischemia, so these are all caused by atheroma. The atherosclerosis. So the atheroma, the atherosclerosis, complication is ischemia, a complication is thrombosis, a complication is aneurysm. And these cause a lot of conditions which we are unfortunately only too familiar with. Ischemia can lead to angina, angina pectoris. This is caused by myocardial ischemia. So when there's a reduced blood supply through this narrowed component here, in this case in the coronary arteries, so it's supplying the myocardium, not enough blood is getting through to that area of the myocardium. And this means the metabolism will change. And it changes from aerobic with oxygen to anaerobic with the production of lactic acid. And we believe that's what causes the pain, the accumulation of lactic acid in the myocardium. So angina, very often angina of effort, it comes on when the pain comes on when the patient is exercising. And transient ischemic attack, TIA, is caused by a reduced blood supply to the brain for a period of time, giving features very similar to a cerebrovascular accident, but they resolve because they're caused by ischemia as opposed to infarction. And another one we see quite a bit of is the peripheral vascular disease, where there's reduced blood supply, particularly to the limbs. So these are all complications of ischemia. Very common conditions. There's others, but they're probably common ones. So the ischemia caused by the atheroma. Now, if we go back to this diagram, what can happen here is if there's supposed to be a roof on this atheromatous plaque here. But if that's damaged, if the roof of the plaque is damaged, then the blood can come into contact with the core of the plaque. And the core of the plaque is atherogenic. well, it's atherogenic, there's atheroma, but the core of the plaque it will promote coagulation. So if the plaque ruptures and the blood comes into contact with the core of the atheromatous plaque, then what can happen is the blood clot can start to develop. So blood clot can develop, and the blood clot, where there's not supposed to be one, is called a thrombus. Of course, there's never supposed to be a blood clot within the lumen of an artery. And if that thrombus is in the coronary arteries, then that can lead to myocardial infarction, or cerebrovascular accident if it's in the cerebral vessels. CVA or stroke. MI, of course, is MI, myocardial infarction, MI. Or it could occur in the mesenteric vessels affecting the gut. Resulting in an area of the gastrointestinal tract which loses its blood supply. Or it could affect the limb, acute limb ischemia, or actually infarction. So if the blood supply is completely blocked off, so if the clot here completely occludes an artery or an arterial branch, then this area of tissue here will die altogether. That's called an infarct. An infarction, the area of infarct, that tissue will die, unless you can restore the blood supply very quickly, of course. So these are still complications of atheroma, but this other set caused by the thrombus formation. Another set of complications there. Now, aneurysm is a weakness in the wall of the blood vessel, and that can affect the aorta, for example. So we can get, it affects the abdominal aorta, that causes abdominal aortic aortic aneurysm, known as a AAA. Now, if that happens, going back to this diagram, the wall of the vessel basically ruptures, and that means we get a complete communication between the blood in there and the outside world, and we can get massive hemorrhage into the abdominal cavity. Or if it's in the thoracic cavity, it can be a thoracic aortic aneurysm. The ones we tend to see most in hospital are the abdominal aortic aneurysms. Now, we can send these to the vascular surgeons if we catch them early enough, but by the time we rupture, the patient's prognosis is poor because of the torrential blood loss. An aneurysm can also cause a cerebral hemorrhage. Stroke, causing stroke. Of course, if you're watching in the States, you don't have an A. In the UK, we have an A for hemorrhage. So we can see that aneurysm, weakness in the wall of the blood vessel, is also a complication of atheroma, but can cause another set of pathologies. So that's just looking at two conditions affecting the systemic arteries. We've looked at hypertension, and we've also looked at the complications of atheroma. There's an old saying in medical nursing circles that you're as fit as your arteries. And to some extent that's true, because if you've got good arteries, you're getting good blood supply to the tissues of the body. If you've got healthy systemic arteries, and you won't get this list of very common conditions that we've just considered. So we need to learn how to advise people on preventing atherosclerosis and managing it early if we are aware of its presence. So that was systemic arteries. Next, I think we'll look at, if we're working round, I think next we'll look at systemic veins next. So we've looked at pulmonary arteries, we've looked at systemic arteries, and in the next video clip we'll consider disorders of systemic veins. The systemic veins being the veins draining the systems of the body back to the right atrium. We now want to think about the systemic veins. Now these are the systems of the body here. This represents the body. So we have the systemic capillaries, the systemic venules draining into larger systemic veins, ultimately draining into the inferior and superior vena cava, which are going to drain into the right atrium. So what can possibly go wrong here? Well, we notice that there's a pressure of about 3 to 8 millimeters of mercury there in the central veins. And if someone loses a lot of blood, they will develop or indeed if they lose fluid of any sort, they're going to eventually become hypovolemic. Low volumes, hypovolemia in the blood. So for example, after hemorrhage, the blood volumes can drop. Or after burns patients can lose an awful lot of fluids. Or dehydration, possibly caused by diarrhea and vomiting, for example. Very common problem in children, because children have much lower blood volumes than adults. So diarrhea and vomiting, especially in young children, needs to be taken seriously, and we need to give them fluid replacement at an early stage, preferably with oral rehydration salts. But of course in healthcare we often give intravenous fluids. If you think about it, when we give intravenous fluids, those fluids are going into the systemic veins. The veins in the arm are systemic veins. And if we give too much, that can lead to fluid overload. Fluid overload, where there's too much fluid in the veins and we can get an increase in systemic venous pressure due to fluid overload. This is usually caused by something that we do wrong in healthcare, so it's what's called an iatrogenic disorder. Iatros is the Greek word for doctor, genic is to begin. So something literally that begins with the doctor. So make sure we give the right amount of intravenous fluids. Now another condition that we can get affecting the systemic veins is chronic venous insufficiency. Now I'm not going to deal with this in great detail because it's dealt with in other places, but you know that veins have valves in them to ensure the one-way flow of blood. The veins have valves, but basically if these valves fail, then the blood is going to dam back, forming a column of blood. And the pressure at the bottom of this column of blood is going to be higher than it should be, because instead of having little columns of blood in between the valves, we end up with one big one because the valves have failed. And that's going to lead to chronic venous insufficiency via the mechanism of chronic venous hypertension. So chronic venous insufficiency caused by chronic venous hypertension. Now this is normally affecting the veins in the legs, is the most common place. It can affect the arms as well, but the legs is the most common. And this gives us clinical features such as edema. And we get the brown staining. The hemosiderosis. But it can lead to venous ulcers, which are painful, and it can also lead to infection. In fact, venous congestion is painful anyway, especially after exercise, because the limb becomes over-engorged with blood. So, chronic venous insufficiency causing backlog of blood, particularly into the legs. But another common cause of systemic venous hypertension is right ventricular failure. So we need to think about right ventricular failure. RVF, the right ventricular failure. Now, we have noticed that right ventricular failure can develop secondary to lung disease. So if there's problems in the lungs where there's not enough oxygen in the alveoli, there's going to be a reflex pulmonary arterial vasoconstriction. It's going to close down. And if that happens, especially all over, if there's a vasoconstriction in the pulmonary vessels, the total lumen is reduced, making it harder for the blood to get through the reduced lumen. That's going to cause a backlog in pressure, meaning that the right ventricle has to work harder to pump the blood out. The right ventricle will compensate by enlarging. There'll be a right ventricular hypertrophy, and over time there'll be a right ventricular failure. And if the right ventricle can't work properly, then blood will be left in the right ventricle at the end of ventricular systole, damming blood back into the systems of the body. So right ventricular failure will lead to systemic edema. This is why in patients with chronic obstructive pulmonary disease, for example, they become blue and bloated. So they're blue because they're cyanosed, because the lungs aren't working properly, so they're not getting enough oxygen in, but they're also bloated because they're accumulating this fluid. This is why we need to give the long-term oxygen therapy. When we give long-term oxygen therapy, we increase the amount of oxygen in the lungs, and that limits the vasoconstriction, allowing vasodilation, reducing right ventricular workload. But the most common cause of right ventricular failure actually is that it's secondary to left ventricular failure. So if the left ventricle is not working properly for whatever reason, then the blood's not being pumped out of the left ventricle, so the blood is going to dam back into the lungs. And over time, that's going to make it harder. Because the blood's damming back into the lungs, that's going to make it harder for the right ventricle to pump blood into the lungs. So if the left ventricle is not working properly, the blood can't get from the left atrium to the left ventricle, it's harder to get out of the pulmonary veins, it's harder for the pulmonary veins to drain the lungs. That's going to increase the pressure in the lungs, meaning the right ventricle has to work harder, causing right ventricular hypertrophy and right ventricular failure over time. So it's important to realise that left ventricular failure can cause right ventricular failure. And indeed, it will work the other way around. Right ventricular failure will lead to left ventricular failure. So often you get a combined heart failure. But still thinking about the right ventricular failure, when there's right ventricular failure, it's most commonly caused secondary to left ventricular failure or lung disease, as we've said. But it can also be caused, right ventricular failure can be caused by failure of the tricuspid valve or the pulmonary artery valve. Because if the one-way flow of blood through the body is not ensured, there can be regurgitation of blood, meaning the blood can't get from the systemic veins into the right atrium. So these patients are often very tired and they're often breathless. They get tired because the blood's not circulating, the blood's not clearing from the body properly, so there's going to be congestion in the body. This is why we call it congestive cardiac failure, because there's congestion. And very often these patients, as we've said, are distended. They can be nauseated because of the accumulation of fluid. And because the blood's not draining from the top half of the body, there can be raised jugular vein pressure, jugular venous distension. But can you see the blood's not draining properly from anywhere? So it's not draining properly from the liver, for example. So the liver isn't draining properly. And that can cause enlargement of the liver. This is a cause of hepatomegaly. And the liver can be tender because the capsule round about the liver gets stretched. But the enlargement in the liver tends to be smooth enlargement of the liver. And you can even get free fluid accumulating in the abdominal cavity. So quite a lot of features we can look for that indicate the presence of right ventricular failure. But as we've said, right ventricular failure over time will lead to left ventricular failure. Just the same as left ventricular failure over time will lead to right ventricular failure. So that's just a few things that can go wrong with the systemic veins. Hypovolemia, fluid overload, the disease of the valves affecting the veins, or disease of the right ventricle. It's maybe just worth mentioning that if the disease is localized, for example, if it's a disease of the valves in one leg, there can be swelling in one leg but not the other. But with these systemic conditions, such as right ventricular failure, the clinical features are more likely to be bilateral. They'll affect all the systems of the body, but there's probably going to be swelling, probably equally in both legs. So consider more localized causes, but consider systemic causes. Now, for the last section in this mini-series, we want to look at the pulmonary veins. What will cause an increase in pressure in the pulmonary veins? Well, the blood is draining from the lungs, from the pulmonary circulation, back through these pulmonary veins. 4 pulmonary veins actually enter the left atrium. The blood from the left atrium goes through to the left ventricle and then out to the aorta. So I think you can probably see that if the left atrioventricular valve, the mitral valve, was not working properly, then when the left ventricle contracted, the blood could be ejected the wrong way. I mean, some will go that way, but some will go back as well, and that would increase the pressure in the veins. So failure of the mitral valve would lead to pulmonary venous hypertension. As would failure of the aortic valve. After ventricular systole, the aortic valve would normally close to prevent regurgitation of blood from the aorta back into the left ventricle. So failure of each of those valves would be a problem. As would failure of the left ventricular myocardium. So here we have the left ventricular myocardium. Thick myocardial tissue. And this can fail, causing left ventricular failure. Failure of the left ventricle. And as with many conditions, as we've seen, it can be acute or it can be chronic. There can be an acute or chronic form. Now, the acute form can be caused by valvular failure, but the most cases I've seen of acute left ventricular failure have actually been caused by acute failure of the left ventricular myocardium, normally caused by an infarction. So if there was an infarction to an area of the myocardium, that area would no longer be contractile, unless you rescue it, of course. And that can result in reduced left ventricular contractility. Now, we've got the normal pressure there supposed to be about 12 to 14 millimeters of mercury. If the back pressure rises due to left ventricular failure or valvular failure in the pulmonary vessels, if the pressure rises to about 20 millimeters of mercury, you'll start to get interstitial edema. But if the pressure rises to about 25 millimeters of mercury, then pulmonary edema will start to develop. So if we think about the lungs here, we've got the alveoli. The small bronchial passages go into the alveoli. And if the pressure increases, fluid will start to accumulate first in the interstitial spaces, interstitial pulmonary edema. But then the edema will start to accumulate within the alveoli themselves. And I think you can clearly see that if there's fluid in the alveoli, the oxygen cannot get to the respiratory surfaces. And in the same way, the carbon dioxide is not going to be able to get out because the whole area is waterlogged. So there can be an acute pulmonary edema. Now, one of the first features we get in this is orthopnea. Ortho actually means straight. Pnea means to do with air or breathing. Now what happens here is, if someone's imagine someone's lying down here. This is the chest when someone's lying down. That's the head here. Now if they're lying down, here's the lung fields. And if they're lying down, the fluid seems to go all over the lung fields. Making it difficult to breathe. They can't get the oxygen in, they can't get the carbon dioxide out. So shortness of breath when lying down. But then when we sit them up to a sitting up position, what seems to happen is the fluid drops to the lower part of the lungs. And you might know from x-rays you get these characteristic so-called small curly bee lines in the periphery of the lung field. We can see these fluid levels. But what this means is that this top part is actually left free of fluid. So gaseous exchange can take place more freely. So the assumption is that the amount of fluid in the lungs is the same, but here it's all in one place when the patient's sitting up. So we can manage the patient leaning forward in the so-called orthopnic position. And when it's severe, when pulmonary edema is severe, there's a great increase in pressure. As you probably know, that round about the alveoli, there's an extensive network of pulmonary capillaries. And these are going to drain out into, of course, these arrive from pulmonary, they arrive from a pulmonary arterial. So the blood's going to go into a pulmonary arterial, leave via a venule. But if the pressure here is greatly increased, because there's back pressure here now, because of the acute left ventricular failure, because of that back pressure, the pressure is greatly increased in here. We're going to get the pulmonary edema, but if the pressure is very increased, that can actually burst some of these blood vessels and the red cells will leak out. So we'll end up with red cells in the alveoli because of the severely increased hydrostatic pressure in the pulmonary capillaries. And this blood's going to go in mixed with the mucus. It'll eventually go up and it will be coughed up as pink frothy sputum. So pink frothy sputum in combination with orthopnea. Now if you see the pink frothy sputum, that's a severe clinical feature. We need to, that's a bit of an emergency. You can get it in high altitude pulmonary edema as well. High altitude pulmonary edema, so-called HAPE. And we use the American E for edema. The other one, of course, is high altitude cerebral edema, HACE. So the pink frothy sputum. So the orthopnea of the pink frothy sputum. Features of the severe pulmonary edema. Now the chronic form of left ventricular failure can be caused by hypertension. In hypertension, the blood pressure here is high, so there's an obligatory high output from the left ventricle, eventually causing ventricular hypertrophy, cardiomegaly and failure. But also we've said ischemic heart disease and disease of the valves. Also anemia. Anemia is a surprisingly common problem. Do be aware of the risk of anemia in your population. Anemia affects something like 20% of the world's population. And what that means is that the left ventricle has to work harder over a long period of time to get the blood circulating, to get the oxygen around to the tissues of the body. It's another obligatory high output condition. So these patients are going to be tired with left ventricular failure, short of breath on exertion, dyspnea on exertion, orthopnea. Very often when they're lying down at night, they get what we call nocturnal dyspnea. Because when they're lying down at night, as we've seen, the fluid can go all over the lung fields. If you listen to the chest, there'll be crackles, crepitations. To try and compensate, initially the patient has a fast heart rate, and the heart will, as we've said, increase in size because of the hypertrophy. So, the pulmonary edema is caused by the left ventricular failure because the blood can't drain back in. Pulmonary edema. Now, over time, the left ventricular failure will also lead to right ventricular failure. So we get a combined cardiac failure. But this diagram explains perfectly why the right ventricular failure is going to dam back, causing the systemic edema, why the left ventricular failure is going to dam back, causing pulmonary edema, whether that be acute or chronic. So very simple diagram, but it actually explains quite a lot of cardiovascular disease. Well worth memorising this or a simple or similar diagram like this so you can use it in your own teaching.